had the opportunity last September to be in Beijing with Margaret Chan, the Director General of WHO, when she was launching the World Health Report for 2013. When she was launching it in Beijing, the World Health Report, as you know, focused on universal health coverage, and particularly research on universal health coverage. And Margaret, in her opening comments, said that when WHO did a review of the research on universal health care coverage, the single greatest source of financing for universal health care coverage comes from the HIV/AIDS community. And I never had heard that, but I talked to the lady and she said, yeah. She said, we have underinvested in research in universal health care coverage, but the bulk of the money that has come into universal health care coverage research on how to get services to the people actually comes from the HIV experiences. And I pick up on Purnima's comments earlier too about maybe some of the lessons we continue to learn in the HIV community. Now, this presentation is not about the HIV/AIDS epidemic surveillance and in Asia and the Pacific, but I did want to just present two slides to show you where we are in Asia and Pacific. If you take a look at the graph on the left-hand side, it shows you data from 1990 until the year 2012. And then if you take a look on the right-hand side, that shows you where the infections took place last year. So I'll let you just kind of quickly look at that, but if you trust me, I can say that there's 5 million people living with HIV/AIDS here in Asia and the Pacific. Last year we had 350,000 new infections. This right here, 350,000 new infections, 5 million people living with HIV. About a third of them, about 34% of the people living with HIV in our region are women. And we had about 250,000 deaths last year. So if you say, well, aren't we doing great? Well, if you take a look at the long trend, yes, since 1990, from the year 2000, we actually have seen an impressive 26% reduction in new HIV infections in our region. But for the last 5 years, since 2008, 2009, 2010, 2011, 2012, 2013, we have actually seen no decline in new infections in our region. The infections have really leveled off at around 370,000 new infections every year. So great progress, but it's stalled in recent years. And I mention this because then it gets into our dialogue, well, why is that and what's holding us back? We can see that some countries in our region seem to have found some really impressive formulas for success. Yesterday we heard about Cambodia, Myanmar, Nepal. We could also talk about Thailand, India, 57% reduction in new infections. And if you talk to the national leadership, including the Prime Minister of India, they will say that their success was making sure that money was focused in on key populations. The voice of the voiceless, those who are marginalized, sex workers, drug users, men who have sex with men and transgender populations, they got the programs to the communities most at risk. But other countries, and you see now in our region, even though we have real success stories in our region, some of the countries in our region, those epidemics that were really low and slow for many years are now actually moving very fast and furious. Countries such as Indonesia, Pakistan, the Philippines. Indonesia is the fastest growing epidemic in terms of the numbers of new infections, but the quickest growing epidemic in our region is the Philippines. And it's gone from less than 1 infection per day to about 14 infections per day. In fact, this chart here actually underestimates the epidemic in the Philippines. It's around about 5,000 new infections every year. So what's happening in some of these countries that isn't happening in others, or at least not at the level that it needs to be? You can see that this is another chart, I won't go into it now, but if we continue to do what we're currently doing, we will not meet the targets that were set by member states in 2011 at the high-level meeting in New York. So here in Asia Pacific, we actually need to reduce our new infections by 50%, but as I mentioned earlier, they haven't gone down. So now this is a point that I'd like to just stress a little bit about community systems. In our region, Asian Pacific, you take 58 countries from Afghanistan all the way to the Solomon Islands, from Mongolia down to New Zealand. In these countries, there is no country where HIV infections are more than 1% of the adult population. The two highest national prevalences are in Thailand and in Papua New Guinea, about 1% of the adult population. But where can we find the epidemic are among key populations. And in this chart, it shows infection rates among men who have sex with men, where countries more than 5% of men who have sex with men are HIV positive, people who inject drugs, and female sex workers. So you can see that even though in countries, no country has more than 1% of the adult population infected, but in many of our countries, in fact in these 12 countries that account for 90% of the infection, populations among key populations are really where we need to be working in the community and where we need to make policies, laws, policies and practices, and money that works for those individuals. I could give you an example. A country in South Asia, our region, has an $18 million grant from the Global Fund. The epidemic in the country is 40% among men who have sex with men. But when we did an evaluation of where that $18 million from the Global Fund went, only $7,000 reached the MSM community. So there's the epidemic, and there's the money, and we're not making it work. We also know that in our region is that these are different cities in different countries in our region, and across the top you can see men who have sex with men, people who inject drugs, female sex workers, and transgender. And you can see these are the prevalence rates, sometimes as low as 5%, sometimes as high as 30%. Now, if we had had this discussion 2 years ago, I can tell you quite frankly, there would be no data for transgender populations. And when I came on board in 2010, I said, well, what is the data for transgender? And the answer was, well, you know, they're kind of a hard population to talk about. Governments don't feel comfortable, we don't collect data, and besides, it's a small group of people. Well, today we can say in Asia and the Pacific, there's about 10 million transgender populations, people, in our region. And if you take a look at this, where, you know, ranges of 9 to 10% infection rates to 30%, and there's 10 million people who are transgender, if we're not reaching that population group with user-friendly services in a way that the community can identify that these are value-added services that respect me, we're not going to get on the top of the epidemic with transgender. I think yesterday we heard a number of people say if you don't measure it, if you don't account for it, it doesn't happen. And I'm glad that countries in this region are increasingly collecting better data on transgender populations. We could say the same thing for other population groups. But in the interest of time, let me move forward. How well are we doing for coverage in these populations? This is a slide with lots of data. You can maybe pick out your favorite country and find out among the key populations, among men who have sex with men, female sex workers, so among female sex workers, men who have sex with men, and people who use drugs, how well are we reaching? So like here's the regional average, these dotted lines, and then how well, like for example, we're in the Philippines, so let's just talk about the Philippines for a minute. We said it's a fast-growing epidemic. About 63% of the female sex workers are being reached. Yet in an epidemic that is principally being driven by men who have sex with men in the Philippines, we're only reaching 23%. And because of punitive, outdated laws regarding harm reduction and opiate substitution therapy in the Philippines, we are not reaching drug users at all. And yet MSM and drug use accounts for the real epidemic. So we have health systems in place that are not reaching where the epidemic is. Now, I'm going to just talk a little bit about treatment. We know that treatment is great for two things. When a person gets under treatment for their HIV infection, it saves their lives. And the earlier they start treatment, the better the long health care outcomes are. But the second wonderful thing about treatment is that it means the person will be unable to transmit the virus to anyone else. So treatment is prevention, and prevention and treatment is great care and support. But in our region, we have not been able to scale up treatment the way we need to. Oh, went too fast. We know that here we've seen an 18% reduction in death due to HIV, and almost all of that is accounted for a scale up in access to treatment. Today, about 50% of the people who need treatment today are receiving treatment. But it is also true, half of the people that need treatment today are not receiving it. So what's the problem there? What's holding us back? Well, if I don't know my HIV status, is Steve Krauss going to go to any health center and start taking ARV medicines? Of course not. No one would. And yet in our region, the key populations, less than half of all of them know their HIV status. So if I don't know my HIV status, will I access treatment? Of course not. Then we say, well, why don't I know my HIV status? And it gets into these things that Purnima was talking about. Not working side by side, but together. How comfortable do we feel in the sexual and reproductive health community providing an anal swab for gonorrhea for a man who has sex with men? How comfortable do we feel about reaching out to communities of sex workers and making them feel at home in the services they seek? And to transgender populations, how do we even know how to do a physical exam? And these are the kinds of things that we need to take a look at in terms of making community systems work better for people. Okay, I see I have 3 minutes. I can just say this is different data for different population groups. I can tell you the situation is the same for drug users, men who have sex with men, transgender. Well less than half of the people know their HIV status. So, you know what, I'm going to just move forward and talk about the last two things. I want to talk about laws, policies, and practices, and money. When we talk about making community health systems work for people, this is the legal environment in which we operate. I once, last year, in a large country in our region, I met with the National AIDS Program Manager. And I said, your epidemic is principally among men who have sex with men and female sex work. And yet here's the punitive legal environment in which you operate. And the National AIDS Program Manager, a person who's really smart, he said, Steve, and I quote, I'm a medical doctor, and these issues about law are not my concerns. So if I'm engaged in activity that is punitive and against the law, and we're trying to reach people, and we believe things like consensual sex between two adults in private is illegal, how do we then access services? And how does the community access us? We can say that in our region we have glowing success examples of countries that have changed their punitive laws so that the community can participate in the health services. And these are examples of where countries as small as Fiji and countries as large as China and India have actually made impressive progress. Who would have thought, for example, that in Bangladesh and Pakistan, that they now acknowledge as government policies a third gender, male, female, and transgender. These are remarkable achievements. So the last little thing, again, just because of time. I'm going to just talk as a final point about money. This shows that the green bar shows the increase in national expenditures for their national response. And the red shows international resources. And so in our region, the good news is more and more countries are using their national resources for their national response to HIV. International funds have leveled off. But the green chart here on the right shows where that money is being spent on prevention and particularly prevention for key populations, such as people who use drugs, sex workers, and men who have sex with men. And you don't need me to tell you, the data is very clear that where the epidemic is and where the money goes is not the same. And, last slide, if you take a look at key populations in our regions, even though national funds are increasingly being invested in their national response, countries in our region are relying on international monies to reach key populations. What does this mean? It means that in our countries, one after another, governments and national programs are not using their national resources to their citizens who are different than 80% of the population. We're not using our own resources to reach our people who have the right to health, the right to participate, and community systems cannot reach those who need services. I'm going to stop there and just say that if we're going to get to zero new infections, we have to take a look at strengthening our political leadership and our own national ownership. A man who has sex with another man is a person. And every person has the right to health. And yet, in environments that national leaders are unwilling to talk about all their people, is not a system that allows for community health care services. Community involvement in leadership, I think we've seen great examples, and our region is loaded with them, of where there's genuine partnerships, where the laws, policies, and practices and the health systems and the communities work together. Our challenge is to scale that up, put money where our epidemic is, and make sure the political leadership supports that. Thank you so much.